Management, Dr. Meena Chandram sir and Dr. Prabhakaran for providing this opportunity to me. In today's lecture, we'll be diving into the practical aspects of managing common skin conditions, which are commonly neglected. We'll be focusing on ethical practice, avoiding common pitfalls, and ensuring best possible outcome for our patients. Let's get started. This will be a very short presentation. So, we are all taught in the medical school, primum non nocere, first do no harm. As medical professional, our guiding principle is this: in a competitive world of healthcare, it can be tempting to treat every patient. However, in dermatology, especially, this can lead to unintended consequences. Just remember, skin being a non-lethal condition doesn't mean that the treatment can affect the patient. It doesn't mean that everybody can treat all the skin disease or every skin disease. There are few skin diseases which are beyond your scope. When you feel like you are not confident, better refer the patient to a specific to the dermatologist. Patient's comfort and long-term health are paramount. This must be considered always. Let's see the 9 common mistakes what general practitioners and other specialists make. Itching in old age, this is a very common problem. So, no first generation antihistamine in old age patient unless and otherwise other options are not available. So, itching is a very common symptom in dermatology practice. When selecting an antihistamine, consider patient's age and comorbidities. First generation antihistamine, while it is effective, it can cause significant sedation, increasing the risk of falls, especially in elderly patients. And in males with benign prostatic hyperplasia, because of the anticholinergic effect, they can exacerbate urinary retention. So, opt for a second generation antihistamine whenever possible. So, this is the first point to be remembered. Soaps in dermatology prescriptions. Now, let's talk about the overuse of medicated soaps. Ketoconazole and permethrin soaps are commonly seen in most of the general practitioners' prescription. Although they may seem to be valuable tools, they are not the panacea. The idea that every itchy patient needs soap is a marketing gimmick, and these medications need sufficient contact time for absorption. So, the formulation is wrong. Soaps do not help you in curing a skin disease on its own. So, that must be kept in mind. Indiscriminate use can lead to resistance and unnecessary expense for patients. Instead, focus on accurate diagnosis and targeted treatment. If you cannot do it, please refer to the dermatologist. Diet restriction in dermatology. It's not needed in most diseases except a very few. Diet plays some role in dermatological condition, but we must avoid placing a huge part of our explanation on overly restrictive diets without clear evidence, because it's of minimal impact. It has a minimal impact on patients. Dermatitis herpetiformis is the only disease where diet is known to have a strong correlation with gluten, and avoiding gluten can improve the disease. Balanced diet is the key. Don't blindly impose diet restrictions on patients, because it can lead to nutritional deficiencies and negative impact on quality of patients. Genital dermatosis. This can be challenging because many patients are hesitant to discuss the issue openly. They resist giving proper history, and we as doctors, we give them antibiotics and send them on their way without properly investigating them. So, this might lead to missing sexually transmitted infection cases. So, westernization has increased the prevalence of STI in our community right now. So, there are a lot of STI cases. If you don't suspect them, then you are going to miss all those cases. So, build trust with your patient so that they are comfortable sharing their private issues in their life. Remember, we as dermatologists, we are trained to handle these situations. If you suspect STI at any moment, better refer them to us or to a nearest NACO center, because STIs, they need the treatment of both the patient and the partner. Holistic STI screening has to be done, because a patient with a single STI can have other STIs too. So we as dermatologists are trained in that, so trust us to do the best for your patients too. Steroid injections in the arm and buttock, we don't use it. I've been practicing for the last 5 years. I have not used a steroid injection in the arm or buttock, because steroid injections, they can give a quick fix to the symptom of the patient, but they come with significant long-term side effects, especially hypertension, diabetes mellitus, osteoporosis, hypokalemia, hyperlipidemia, avascular necrosis of the femur, and injection site abscess. All these are potential complications, and when you do not know the long-term side effect, patients, because of the quick relief that they get after the injection, their brain is trained to get the IM injection again and again and again, and leading finally to long-term side effect. So avoid using IM steroids in routine dermatological practice. Fixed drug combination creams, again we don't use. This is a picture of fixed drug combination cream. These are polyvalent steroid creams. In the picture you can see that it contains a steroid, antibiotic, antifungal and antiparasitic agent. The problem with that is it leads to misdiagnosis and treatment failure. They can mask the underlying condition. It makes making a diagnosis more difficult. It increases the treatment costs, prolongs illness, promotes resistance, and it can cause steroid-induced skin damage like thinning, hair growth, hyperpigmentation and telangiectasia. Let's say you have a patient in the OPD and you have no clue what the diagnosis is. Please don't give this cream, because this contains antibiotic, antifungal, antiparasite and a steroid. So either it's an allergy or an infection, somehow the patient will respond, but at the same time it just reduces the symptom or incompletely cures the infection, and ultimately the patient can have a disease for a long duration of time, and it makes our job very difficult because it changes the morphology of the skin lesion. So when you are not confident of the diagnosis, please don't give this cream, because the pharma people, when they promote this cream, they give it to you as a magic cream which can solve all the problem. That's how it's being marketed to the general practitioners. So please be aware of this. Depigmenting creams, again a double-edged sword. Everybody wants to be fair nowadays, they want to look good. Depigmenting creams are commonly abused, and it's being used inappropriately by other specialty departments, especially the hydroquinone cream, because it has to be used under the supervision of a dermatologist. It can lead to paradoxical hyperpigmentation on long-term use, and use of steroid creams for depigmentation should also be avoided because of the risk of skin damage. Treatment of ringworm, fungal infection. Ringworm is the most common infection that we see in our OPD, and you might have also seen. But because the topical antifungal creams, they often fail to address the systemic fungal infection when the infection is pretty severe. This is especially true for patients who have used steroid creams, or they have extensive tinea that involves more than 10% of the body surface area, and it involves hair, nails, palms and sole involvement, or when the patient is immunosuppressed with drugs or due to the disease. In these cases, topical antifungal creams will not work. So you should know when to refer a patient with ringworm infection to a dermatologist. In these cases, you should refer them to a dermatologist, and if there is no improvement after using antifungal creams for 2 to 4 weeks, please refer them again to dermatologist. So how to use antifungal cream. I will give you a pro tip, that is follow rule of 2. It's very easy to remember. So you'll have to remember 4 2s. You'll have to use 2 topical antifungals of different class, and it has to be used twice a day. So you'll be applying 4 times a day, and it has to be applied over the rash and 2 cm around the rash, and you continue the cream 2 weeks beyond the disappearance of the rash, that is cure. If you are not able to cure the patient, please send them to us. We'll take care of them. So to summarize, prioritize patient safety. Always adhere to principle of primum nocere. Choose antihistamines wisely. Consider patient's age and comorbidities. Avoid use of medicated soaps. Focus on accurate diagnosis. Be cautious with dietary restrictions. Avoid unnecessary limitations. Address genital dermatosis. Always consider STI, refer them when needed. Avoid intramuscular injections, I mean intramuscular steroid injections. Balance the weight, risks and benefits. Say no to polyvalent steroid creams, they complicate diagnosis and treatment. Supervise depigmenting cream use, prevent complications, and refer complex fungal infections. Don't hesitate to take our help. Follow rule of 2. Thank you everyone. Thank you for the opportunity.